Hello everybody. Welcome to No1doctor channel. Today we will discuss one of the common surgical problems. Welcome doctor.
Welcome doctor for you and for your channel subscribers.
Doctor. A 25-year female patient sustained severe burn injury. How will you manage? What measures you will take at the site of accident?
When seen at the scene of accident, remove her from source of heat to avoid further injury. Maintain airway, as victim may sustain respiratory tract burn due to inhalation of smoke or flame. Maintenance of airway and breathing is essential before sending the patient to hospital. Start an intravenous line and start Ringer's lactate fluid infusion before sending her to hospital. If flame burn, there is a role of cold water lavage. Irrigating with copious amount of cold water. Cold water sponging help in minimizing the depth of tissue damage due to the excessive temperature. Transport quickly to hospital. On arrival at ER? Like trauma management, primary survey and resuscitation is the first step by ABCDEF. A. Maintenance of airway. B. Maintenance of breathing. C. Maintenance of circulation. D. Assessment of disability. E. Exposure in a controlled environment. F. Fluid resuscitation. Secondary survey, a detailed history and a head-to-foot examination. Detailed history about the mechanism of burn injury. Flame burn or scald. Duration of contact. Time of accident. Pain. Respiratory distress. Any other injury. Any associated medical illness. Examination. Assess the surface area of burn by following the rule of 9. Assess the depth of burn. Superficial or deep burns. Features of other injury as patient might fall after sustaining burn. So, a thorough head-to-foot examination is essential.
Doctor. How will assess the amount of burn area?
In adult this is by following the rule of 9. Head and neck. 9%. Front of chest and abdomen. 18%. Back of chest and abdomen. 18%. Upper limbs. 9% plus 9%. Lower limbs. 18% plus 18%. Perineum. 1%. Assessment of burn area in children. Head and neck. 20%. Upper limbs. 9% plus 9%. Chest and abdomen, front. 18%. And back. 18%. Lower limbs. 13% plus 13%.
Doctor. What are the gradings for depth of burns?
Depending on the depth of burns this may be. First degree burns. Involves only the epidermis, no blister. Only erythema. Heals in 3 to 4 days by peeling off of the epidermis. Second degree burns may be. Superficial dermal burns. Involves the upper layer of the dermis. Forms blisters and on removal of blisters. Wound is pink, wet, sensitive and blanches on pressure. Heals in 3 weeks by epithelialization. Deep dermal burns. Children. Involves the reticular layer of the dermis. Forms blisters and on removal of the blister the wound is white, dry and capillary refilling occurs slowly or absent. Heals in 3 to 9 weeks with scarring. Third degree burns or full thickness burns. Involves all the layers of the dermis. No blisters. The wound may be white, cherry red or black and is leathery, firm in feel, insensitive, do not blanch on pressure. All epithelial elements are destroyed, and there is no potential for healing by epithelialization. Fourth degree burns. Involves all the layers of the skin, subcutaneous fat and the variable amount of deeper structures. The wound is covered by a thick eschar. Alternatively, the burns may also be classified as superficial burns. includes the first degree and the superficial dermal burns. Deep burns involves the second degree deep dermal, third degree or full thickness burns and the fourth degree burns.
Doctor, how will you assess depth of burns?
The depth of burns may be assessed by clinical observation of the wound, as I mentioned before. Superficial burns are sensitive and is painful on pinprick, whereas the deep burns are insensitive. Assessment of blood flow by Doppler, or fluorescein fluorometry or thermography.
Doctor, what are the causes of burn shock?
Hypovolemic shock. Increased capillary permeability due to burn injury causes exudation of fluid out of the intravascular compartment, and there is marked increase in extracellular fluid. The maximum fluid shift occurs in the first 8 to 12 hours. The decrease in intravascular volume is the most important aspect of burns shock. Neurogenic shock. Due to severe pain. Septicemic shock. Due to secondary infection of the burn wound.
Doctor, how will you treat burn shock?
Treatment of hypovolemic shock due to burn is managed primarily with intravenous fluid administration. The fluid is required to replace the intravascular fluid loss. Relief of pain with intravenous narcotic analgesics. Suitable antibiotics for infection.
Doctor, how will you calculate the amount of fluid required for resuscitation?
The amount of fluid required depends on the area of burn and weight of the patient. There are various formulae for calculating the fluid required. Modified Parkland formula. Lactated Ringer's solution 4 ml per kilograms % burn in 24 hours. 50% of fluid in first 8 hours and rest 50% in next 16 hours. Idea of volume replacement is to maintain adequate tissue perfusion. The adequacy of fluid replacement may be assessed by monitoring pulse, blood pressure, urinary output. An urinary output of 50 ml per hour or 0.5 to 1 milliliter per kilograms body weight per hour indicate adequate hydration. An alternative regime for fluid replacement is to infuse Ringer's lactate 1 liter per hour. Check vitals, pulse, blood pressure, and monitor urine output. The rate of fluid repulsement is adjusted to maintain an urinary output of 30 to 50 ml per hour.
Doctor, how do you plan fluid therapy in the post-resuscitation period?
Intravenous fluid therapy in the post-resuscitation period involves replacement of evaporative fluid loss in addition to maintenance fluid. Glucose in water or Ringer's solution or colloids are required to maintain the circulatory fluid volume. Amount of fluid required is 1500 ml per SQM of body surface plus evaporative fluid loss. Evaporative fluid loss in burn patient is equal to 25 times % of burn times SQM of body surface. This fluid may be given intravenously or by enteral route, if the patient can take orally.
Doctor, what are the choice of fluid used for management of burn shock?
Lactated Ringer's solution. A crystalloid solution like lactated Ringer's solution is the ideal fluid required for initial resuscitation. However, in major burns resuscitation with only crystalloid results in hypoproteinemia and causes aggravation of edema. Patients with less than 40% burn may be managed with only crystalloid infusion. Hypertonic saline. Hypertonic salt solution, 240 mg of sodium per liter, is being used with increasing frequency. Patient can be resuscitated with less amount of fluid and in turn less edema. The serum sodium level should be monitored, and once the serum sodium level exceeds 160 mg per liter, the hypertonic saline infusion should be stopped and lactated Ringer solution should be used. In patients with more than 40% burn, associated pulmonary injury, and an elderly patient, hypertonic saline may be used for resuscitation in first 8 hours followed by infusion of lactate Ringer solution. Colloid solution. Earlier colloid solution was used more frequently to increase the plasma colloidal osmotic pressure. But it has been observed that proteins are no more effective than crystalloid solution in maintaining intravascular volume in first 24 hours. colloid should be added to the resuscitation fluid after 8 to 12 hours in the form of 5% albumin or plasma. Dextran solution. Dextran is a colloid consisting of glucose molecules that has been polymerized into chains to form polysaccharides. Dextran with molecular weight of 40,000 is referred to as low molecular weight dextran and has been used in burn shock as it improved the microcirculation.
Doctor, how will you manage the burn wound?
The burn wound management depends on the degree of burn. First degree burn or epidermal burns. No dressing and topical antibiotics are required. This heals in 3 to 7 days' time. Second degree burn. Superficial dermal burns usually heals by epithelialization by 2 to 3 weeks. The wound needs to be dressed with topical antibiotics to prevent infection and layered padded dressing applied. Paraffin gauze, and a thick layer of gauze. The burns in the face and neck are usually treated by exposure method with application of topical antibiotics and keeping the area open. Deep dermal burns, third degree burns and fourth degree burns, does not heal by epithelialization and may heal by granulation with gross scarring. There are 2 options for surgical treatment of deep burns. Delayed operation. The burn wound is dressed in time is allowed for spontaneous separation of the slough, and once the wound starts granulating, the area is covered with split skin grafting. The advantage is avoidance of early operation, but the disadvantage is there is scarring following skin grafting of the granulating wound. Early operation. Surgical management of the burn wound has now become more aggressive. Following resuscitation of burn wound, operative debridement is planned early. Tangential excision of the burn wound is done till a bleeding dermal bed or subcutaneous tissue is reached and the area covered with split skin graft. The skin graft may be meshed to cover a larger area of the defect. The healing process may be expedited by this method. In deep burns with exposed structures like bones, nerves, tendon and vessels, after debridement needs to be covered with skin flaps rather than split skin grafts. If patient's own skin is not available for grafting, what may be done? Cadaver skin has been used for definitive cover. Autologous culture of epithelium has been used with some success. Others like amnion graft, collagen dressings has been used.
Doctor, what are the roles of antibiotics in burn injury?
Infection remains an important problem in burn injury management. There is controversy about routine use of prophylactic antibiotics in burn injury. The routine administration of broad-spectrum antibiotics may result in emergence of resistant strains of organisms. Varied organisms may colonize the burn wound. The common organisms are Streptococcus, Staphylococci, Pseudomonas and E. coli. Infection may be treated by topical antibiotics like silver sulfadiazine cream or povidone iodine cream. Invasive infection is suggested by cellulitis, fever, and positive blood culture. This needs treatment with suitable parenteral antibiotics.
Doctor, how will you achieve tetanus prophylaxis in burn wound?
Burn wound is a tetanus-prone wound. The recommendations for tetanus prophylaxis for wound are: patient is immunized and last booster dose within 5 years. Nothing is required. Patient is immunized and last booster dose between 5 to 10 years. 1 booster dose of injection tetanus toxoid. Patient not immunized, immunization status unknown or last booster dose more than 10 years. Injection tetanus toxoid. Injection human tetanus globulin 250 unit. At 2 different sites.
Doctor, how will you prevent stress ulcers or Curling's ulcer?
In major burn injury, patient may develop stress ulcer, which may manifest with upper gastrointestinal hemorrhage. The stress ulcer may be prevented by using H blockers, ranitidine or famotidine, proton pump inhibitor, omeprazole, pantoprazole, sucralfate.
Doctor, what are the special problems with circumferential burns?
Circumferential burns of the extremities and the trunk poses special problems. Circumferential deep burns of the extremities with swelling beneath the unyielding SR may result in distal ischemia in the fingers and toes. To prevent permanent damage due to ischemia, a sclerotomy extending up to the deep fascia must be performed early. Circumferential burns of the chest and abdomen may restrict ventilation. This may be relieved by longitudinal sclerotomies. The sclerotomy may be done without general anesthesia.
Thanks, doctor.
Thanks for you and for your subscribers.
Thanks for watching. Hope to see you again in next videos. Do not forget to like and share our videos and subscribe to our YouTube channel No1doctor and share our videos with your friends on social media. With my best wishes.